Bo's a paediatric cardiologist and a scientific advisor to the World Heart Federation on rheumatic fever and rheumatic heart disease. She's a fellow of the Australasian College of Physicians and a member of the Cardiac Society of Australia and New Zealand. She received her medical degree from University of Queensland and undertook postgrad training in paediatric cardiology at the Royal Children's Hospital in Melbourne and at Green Lane Paediatric and Congenital Cardiac Services at Starship Hospital in New Zealand. As a clinical cardiologist, she works at the Royal Darwin Hospital and the Northern Territory Cardiac Services, and she's undertaking doctoral studies at Menzies School of Health. And I smile when I say that because she's been trying to finish that PhD, and she's very, very busy. She's committed to a number of different things. Her interests lie in rheumatic heart disease control, early detection via echocardiographic screening, and the standardisation of a diagnostic protocol.
While we're waiting, it's great to be back in North Queensland. As Claire said, I graduated from University of Queensland. I spent my first 3 years as a junior doctor in North Queensland, working on Palm Island, Dumuji, Mornington, far North Queensland. So it's great to be home, and not to mention that my mother lives in Cairns, so she's looking forward to seeing me tonight. So thanks again for the organisers for making this happen. So really, today I would like to talk to you about cardiac surgery and a patient's journey. You had the opportunity to meet our 4 very brave movie stars just a few minutes ago, and what I would like to do today is just to talk through their journey in a little bit more detail to see what was their road to get to Melbourne Children's Hospital to need cardiac surgery. So the first case I would like to discuss with you is Brooklyn. As you would remember from the movie, she's a 7-year-old girl who had her first episode of acute rheumatic fever in 2013. She had a pretty straightforward presentation with high fevers, polyarthritis, high CRP positive streptitis, and a raging cardiac murmur. And her echocardiogram confirmed on admission that she had severe rheumatic heart disease with a very dilated heart. This is a young girl whose family was from Elcho Island, which is about 800 kilometres from Darwin, and her family had already relocated to Darwin because her father needed renal dialysis. And she comes from a very large family with 9 kids in a single household, and you saw her house on the pictures just a few minutes ago. So this is a young girl who had a single episode of rheumatic fever, and when we looked at her echocardiogram, she didn't have any of the chronic changes that Ben talked about. So from looking at her, reviewing her clinical notes, it was very clear that this was the first time ever in her life that she had acute rheumatic fever. She had a very protracted stay in Royal Darwin Hospital, and with initially some improvement on a standard management with bed rest, penicillin, cardiac medications, steroids, and of course benzosine penicillin. But despite this, her condition progressed, and we referred her to Melbourne for cardiac surgery, and on her birthday, on her 7th birthday, she was accepted for cardiac surgery. When she returned from Melbourne to the Royal Darwin Hospital, her heart was fixed. This is 3 months into her illness. But her acute rheumatic fever persisted. Her inflammatory markers stayed high, and she had continuous evidence of sore joints, and the illness continued. So just sort of highlights that surgery fixed the heart. Acute rheumatic fever is a relatively short illness, as Malcolm described, usually around 6 weeks, but you have cases that can last for quite a long time. And eventually she was discharged from hospital 4 months after arrival, and at the time of discharge she was well active, asymptomatic. So that's a story that a cardiologist would look at. But let's see what was happening to her family at the time. She came from a family that was very highly accepting of the medical treatment. They were compliant, to use that word, with the doctors' and nurses' orders. The family was very supportive of every step through the way. Now, Brooklyn herself, she was very ill, very irritable, febrile, unwell, refused to eat, refused medications, to the point that her mother had to stay in hospital with her every single day for those 4 months. And there were 8 other kids at home. The father had to take on the duty of being the the sole carer for the 8 other kids. He had to go shopping. He learned how to cook. He cleaned the house. So it's a whole, in addition to having dialysis 3 times a week with no transport. So you can just see how much pressure this puts on this family who have their best intention is to get Brooklyn better, and they will just do anything for her. Now, this is a pretty sad case. Approximately 10% of all cases in the pediatric population of acute rheumatic fever leads to severe rheumatic heart disease during the first episode. That also means that 90% of the cases have either no rheumatic heart disease, mild or moderate. But once you have a presentation with severe rheumatic heart disease, despite very best treatments, sometimes surgery is not avoidable. So what I would like to do is just to have a look at what could have we done as a health system, as healthcare providers in the room, to prevent Brooklyn needing cardiac surgery. Because this is a very unfortunate story for such a young girl to have such a serious consequences, as you saw from the movie before. So the first thing to look at is really primordial prevention, and that was highlighted by Claire in the first talk. And that's really looking at how can we improve the social determinants of health with regards to providing better housing, better living circumstances, improving the education, nutrition of our communities, especially looking at our indigenous communities, both the Aboriginal and the Torres Strait Islanders. And that's something that we always feel that it's beyond our control as physicians or nurses or dentists or midwives or community health workers, because we often feel that there's nothing we can do and it's not our job, it's a government job or someone else's job. But this is certainly that's something that we need to address, otherwise we will not be able to prevent patients like Brooklyn. Now, looking at primary prevention, Brooklyn had lots of skin sores. He didn't have any specific sore throat before the episode of rheumatic fever, but certainly she came from a household where scabies and skin infections were endemic. So that's one thing as healthcare workers we could have done possibly better, is to make it more acceptable for our patients to come and seek help or deliver services in a different way so we can address the burden of streptococcal disease and associated scabies in communities. And finally, looking at secondary prevention. In this specific case, secondary prevention did not prevent rheumatic heart disease because the first episode of rheumatic fever was so severe. Okay? So really the only way Brooklyn could have avoided surgery is by addressing the first 2 points. The first one, we feel it's beyond our level of what we can offer as clinicians, but certainly the second point is an important one, and this just highlights the importance of not ignoring sore throats and not ignoring skin infections. Okay, so Brooklyn had a cardiac surgery. She's doing very well. She's asymptomatic. She had an excellent repair. What is her life expectancy and what is her future? This is some data from New Zealand, from the Starship Children's Hospital, showing in their populations, when you look at the red line on the top, children who are from New Zealand, so this is the Maori and Pacific children from New Zealand, who had isolated mitral valve surgery. And those of you who don't know too much about New Zealand, one thing that as a health system does really well is they're able to deliver secondary prophylaxis on time to the majority of their patients. So those kids who have cardiac surgery and have good secondary prophylaxis, they have excellent long-term survival following a repair. And the second line, the black line over here, represents children who also had single valve surgery at the same hospital, but they were the patients who came from the Pacific Islands, had surgery in New Zealand, and then returned back home. Now, their long-term survival after the same operation was much inferior. And that is, once again, how long Brooklyn will live will be determined by what kind of health service we as a team deliver. That's including doctors, nurses, community health workers, especially midwifery staff, because it's only a few years away that Brooklyn will be in a childbearing age, and of course our dental colleagues at the back, which is also critical, as we know that a lot of children unnecessarily die from endocarditis following cardiac surgery if they don't receive their timely dental appointments. So we talked about secondary prophylaxis, and we heard some excellent results from Townsville with excellent compliance rates. which is great to see. As Claire showed from the Northern Territory, our compliance rates are really unacceptably low. And for Brooklyn to survive and to have a normal life expectancy, she really needs to have 13 out of 13 needles with 100% compliance. It's not good enough to say that she'll have 80% of the needles. So secondary prophylaxis in her case could not have prevented her heart surgery, because the first time she had rheumatic fever, it was very severe. But now that her heart is fixed, her survival is dependent on good compliance with secondary prophylaxis. So this is really important. And 80% that we talk about, or 50%, that's just really not an option. Because for a child, for a 7-year-old, a 6-year-old child to have severe rheumatic fever at such a young age needing surgery, that means she's at extremely high risk of having a recurrence. So when she's returning to her household of 8 kids or 9 kids full of strep and germs, the risk of having a recurrence is extremely high. So let's talk about second case, Ludovic, the second young boy that you saw in the movie. He's 15 years of age. He was a really lucky boy. The reason why he was really lucky, he was diagnosed with rheumatic fever at just 3 years of age. Had some excellent clinicians who picked it up. He presented with the classic signs of rheumatic fever with polyarthritis fevers, had high CRP with positive strep titers. He was diagnosed at 3 years of age. His echo at the time showed essentially it was normal. And the reason why he's lucky, because from some of the pictures that Claire showed earlier on, when we look at the Indigenous community in Australia, we don't actually know who's at risk. We know about 2 to 3% of the population will get rheumatic heart disease sometimes during their life, but you cannot just, there's no magic test, there's no diagnostic test. We don't know who's at risk and who's not. But Lidibu put his hand up, yes, at 3 years of age, I'm going to be one of those kids who are going to have rheumatic heart disease, and it was picked up, his heart was normal. This would have been an excellent time to prevent rheumatic heart disease in a child who has identified himself so early that he's at risk. So let's have a look at his story. Yes, so at 3 years of age, acute rheumatic fever, classic signs and symptoms. No rheumatic heart disease. At age 7, he had his first recurrence of rheumatic fever. At age 8, he had his third episode of rheumatic fever. And that time, he had severe disease and required cardiac surgery. And of course, having cardiac surgery, problem is all gone and fixed, and many families believe that surgery is a cure and that you no longer have a problem. Almost immediately after surgery, he had an acute rheumatic fever recurrence, and within 1 year, he needed his second open heart operation. That was successful with good results. And at age 14, when I first met him, he came with infective endocarditis. He had horrible dentition. He had not seen a dentist for some years. And he had positive blood cultures, and he had the full-blown endocarditis. That was treated with antibiotics. He survived that episode, and then he needed his third open heart surgery, and that's the one that you saw on the film. This time they couldn't repair his cardiac valves because it had been so damaged and had already had a number of operations, and the only option was in this very young boy. He's only, on the movie, he's only 14. I know he looks much older. To replace both his aortic and mitral valve with a mechanical valve. Now, what does that mean? It means not only he needs his 4 weekly injections for penicillin, but he also needs warfarin, anticoagulation, and INR checks, in addition to his dental checkups. So let's have a look at his story together and see what we could have done along the way from a system perspective, or to prevent 3 open heart surgeries in such a strong boy, though he's not a Geelong supporter. Okay. So this is some of the stuff about where we talked about resolution of rheumatic heart disease. We know that if you're diagnosed with no carditis or mild carditis, especially those kids who have mild carditis at first diagnosis, on secondary prophylaxis, within 5 years or so, 2/3 of the kids will have no detectable disease. This was done on auscultation in the first part of the study, and a subsequent study showed the same thing with echocardiography. So this is really important, that age 3, he goes on secondary prophylaxis, he's compliant, he doesn't need any cardiac surgery altogether. Let's say hypothetically, I've only met him 2 years ago, so I don't know his stories from his younger age, but let's say hypothetically, if he would say to you, I don't want to have injections, I want to have tablets. So how good is penicillin tablets, oral prophylaxis? And this is a study from New Zealand showing that those children who go on oral prophylaxis, within 5 to 6 years, a third of those children will have a recurrence. Now, this is pretty similar data of those children who are not on prophylaxis altogether. About 50% of the kids will have a recurrence without secondary prophylaxis within 5 years. So an oral prophylaxis is a tiny bit smaller based on this study, but essentially it's not going to prevent heart disease. So that would not have been a good option for Edward. So let's be a little bit more specific, okay? Let's talk about numbers. Edward was diagnosed in 2003, and this is some data from the Northern Territory Rheumatic Heart Disease Control Program. And in the first year, he had 4 injections, next year 10, then 5, 1, 1. After his surgery, he was pretty good, had 12, 10, and dropped off again, 6, 9, and 7. So if you add up all those total numbers, over 10 years, out of the 130 injections, he had 65. So that's from systems point of view, we delivered 50% of his injections. And what does that equal to? 3 open heart surgeries. So 50% of injections might as well not be doing anything, because that's not going to prevent needing 1 surgery or even 2 or 3 surgeries. So it's really, really, really important to try to improve our service delivery to meet our patients' demands. And there's some really good examples coming out from Australia, from Townsville. And there's also some positive stories in many smaller communities. But we have somehow together as a team, we have to translate this to the wider community, because 50% or 80% is just simply not good enough. It's not going to achieve what we're trying to achieve, which is to allow children to have a normal, fulfilling life. Okay, so let's have a look at what is the future for Lidivu. Now that he had 3 open heart surgeries, he's 15 years of age, he's got 2 mechanical valves. How long is he going to live? All this effort our nursing staff have put in over 10 years, they delivered every second injection. And I suspect there was probably quite a lot of effort that has gone into it. Surgeons have operated on him three times. There's enormous money and effort and passion and care and love has gone into his care. But what does that result in? Well, this is some data from the Northern Territory from Jonathan Carapiti some decades ago, showing that those individuals who require mechanical valve replacement in a setting of rheumatic heart disease, 50% of them will die within 15 years. So Edward is 15 years of age. When he's 30, he's got a 50-50 chance of being alive. Okay? This could have all been prevented when we picked him at 3 years of age, that he was at high risk of getting rheumatic heart disease. It's way before he had any heart disease. And this is similar, more recent data from New Zealand, once again showing that long-term outcomes with mechanical valves are pretty poor. But that's not all you have to worry about. You don't have to worry about if Lidivu is going to live or die, though that's very important. But there's also other risk factors. Endocarditis, which you already had. And secondly, stroke. Data from New Zealand suggests that kids who have mechanical valve replacements, approximately 50%, half of them will have a major embolic or hemorrhagic event, a stroke, within 10 years. So by the time Lidivu is 25 years of age, there's 50-50 chance that he would have had a stroke. They're pretty alarming figures. On the red line on the top, that shows patients who had a repair. So those children who have a repair, they have much better long-term outcomes because they don't have to take anticoagulation. And they have much better survival rates. But of course, Lidivu already had 2 repairs and he had no other options. But children, especially young people, especially in the childbearing age, it's really important to advocate for valve repair rather than replacement. This is important to have a good relationship with surgical centres and to have an expectation that when you refer patients to surgical centre that a serious consideration is given to repair rather than replacement. Okay, so after all this, right now, Edward is highly compliant with his injections. He had every single injection on time since June 2013. He has his INR every week. He takes his warfarin every day. And once again, just raises the question, why did it take 3 open heart surgeries to get here? So the take-home messages are pretty similar to what had already been said earlier on. It's really unacceptable not to treat sore throats and skin sores in our high-risk population. 80% compliance is simply just not good enough in the high-risk patients because they live in a strep-infested environment and they're at risk of a recurrence every single day. And really we should be aiming, just like Cairns will, close to 100% compliance if possible. Surgery is not a cure. It creates a whole new set of problems and diseases. It's merely a palliation. And it's really important when you have children or adults with severe rheumatic heart disease that it's communicated clearly to them that the surgeon might fix the valve, but the risk of rheumatic fever remains. And one of the messages which is not on there, it's really, really important for all of these children and adults to have regular dental reviews. As Edward's third operation was related to endocarditis with a background of very poor dentition. All right, and I know it's sort of difficult times, and we all try our very, very best to improve the lives of our patients and to improve their service delivery. But we're often faced with really difficult situations, and sometimes it even might seem impossible. Last year, the Dalai Lama was in Darwin, and there was a nurse who put her hand up during his speech and said, look, I work in Kimberley and things are pretty difficult. Our patients are non-compliant, and what can I do to achieve better healthcare for my patients? And the Dalai Lama said, show and practice compassion. So on that note, I would like to tell you, if you're interested in the story of Carlisa and Brooklyn, please watch out for the full documentary. Thank you.